Assalamu alaikum. Now I would like to talk about primary hyperaldosteronism. First of all, if a patient comes with hypertension and hypokalemia, if a person comes with hypertension and hypokalemia, we have to do two things. We have to measure plasma renin activity and plasma aldosterone concentration. If the plasma renin activity if the PAC, plasma aldosterone concentration, and PRA, plasma renin activity ratio is PAC by PRA ratio is approximately 10% or less than 10, then it is secondary hyperaldosteronism. If the PAC, that means plasma aldosterone concentration by plasma renin activity concentration, is more than 20, more than 20, it is primary hyperaldosteronism. In primary hyperaldosteronism, aldo is high and renin is low. On the other hand, in secondary hyperaldosteronism, both the things are high. Both aldo is high and renin is high. And if both the situation is low, that like plasma renin is low and aldo is low, it has some other causes. Okay, if primary hyperaldosteronism, uh, in primary hyperaldosteronism, it it may be due to aldosterone producing tumor, or bilateral adrenal hyperplasia. And in secondary hyperaldosteronism, the causes are renovascular hypertension, malignant hypertension. It may be due to cirrhosis, it may be due to failure, it may be due to heart failure, CCF, cirrhosis, it may be due to use of diuretics, it may be due to use of it may be coarctation and malignant hypertension. So, and most important is reninoma, renin producing tumor. So reninoma, renovascular hypertension, malignant hypertension, cirrhosis, CCF, diuretics, and coarctation. And the last, where both renin is low and aldo is low, these are the cause of Cushing's, corticosterone, congenital adrenal hyperplasia, Cushing syndrome, deoxycorticosterone, uh, deoxycorticosterone producing tumor, and exogenous mineralocorticoid. Deoxycorticosterone producing tumor and exogenous mineralocorticoid. So if there is hypertension and hypokalemia, we have to go through these uh, flow. And after, if the patient has plasma aldosterone concentration and plasma renin activity more than 20, or plasma aldosterone concentration more than 15, then we have to do some confirmatory testing. For confirmatory testing, we will challenge the patient, and that is the Captopril challenge test. We can use other confirmatory testing by giving oral sodium, known as oral sodium loading test, and we can do another test also known as saline infusion test. So three tests in the pipeline for confirming a patient with primary hyperaldosteronism. For before doing this test, we have to follow some protocols, like encourage the patient to liberalize sodium intake. We do not want to restrict sodium intake. We will tell the patient you can take sodium as much as you can on normal level. And before doing this test, the prerequisite is correct hypokalemia. And some drugs should be stopped. That's why this test is a hassle one test. Withdraw drugs that markedly affect aldosterone renin ratio, ARR, for more than 6 weeks. Mineralocorticoid receptor, for example, spironolactone, epinephrine, and potassium wasting diuretics. These should be withdrawn uh, more than 6 weeks. And the other drugs like beta blocker and ARB and clonidine and NSAID should be withdrawn more than 2 weeks before you are doing the test. And for controlling hypertension, you can use alpha blocker like prazosin. You can use a mm, non-dihydropyridine calcium channel blocker. Verapamil diltiazem can be used. You can use vasodilators like hydralazine. These are the drugs can be used before for controlling hypertension. And AC, ARB, beta blocker, diuretics, that means potassium sparing diuretics, these should be stopped. Potassium sparing diuretics should be stopped more than 6 weeks. And uh, ARB and beta blocker, ACE, mm, vessel selective calcium channel blocker, and NSAID should be stopped more than 2 weeks before. Then collect collect blood at mid morning 8 a.m. to 10 a.m. 8 a.m. to 10 a.m. After the patient is out of bed for more than 2 hours, sitting, standing, or walking, and seated for 5 to 15 minutes. You have to collect blood in this manner, like in mid morning 8 a.m. to 10 a.m. after patient is out of the bed more than 2 hours, and for more than 2 hours, and seated for 5 to 15 minutes. When the patient take captopril, when the patient take captopril, must take at morning, and he should be upright position for at least 2 hours. After taking captopril, he should be upright for 2 hours and seated for 5 to 15 minutes. Blood sample are drawn, plasma renin activity and plasma aldosterone at time 0 and at 2 hours after the challenge. At 0 and 2 hours after the challenge, and patient remains seated during these period. Patient remains seated during this period. And plasma aldosterone is normally suppressed by more than 30%, but remain elevated in plasma aldosterone with cutoff value ranging from 8.5 to 13.9 nanogram per dl. And plasma renin activity remains suppressed. Aldo becomes high and renin becomes low. In primary hyperaldosteronism, uh, plasma aldosterone concentration remain elevated. You are suppressing, but still the aldosterone concentration remain elevated. The normal cutoff is remain elevated with cutoff value ranging from 8.5 to 13.9 nanogram per dl. This is the Captopril challenge test, and the other test, oral sodium load test. In oral sodium load test, what we will do, increase sodium intake more than 200 ml, increase sodium intake more than 200 ml per day for 3 days. Oral, if the potassium should be monitored at that time, and potassium supplementation can be given on the third day. uh, on the third day we will collect 24-hour urine and measure aldo, sodium, creatinine level. If the failure to suppress urinary aldo, if the failure to suppress urinary aldosterone, less than 12 microgram per 24 hour, it is consistent with primary hyperaldosteronism. In saline infusion test, what actually we do, the patient stay in the recumbent position for more than 1 hour before and during the more than 1 hour before and during the infusion of 2 liter normal saline IV over 4 hours at 8 a.m. with BP and heart rate monitoring throughout the test. Failure to suppress the post-infusion plasma aldosterone concentration less than 10 in primary hyperaldosteronism. Normally, plasma aldosterone concentration level is less than 5 normally, and 5 to 10 nanogram per dl is bilateral idiopathic hyperplasia. If plasma aldosterone concentration is less than 10, uh, it is primary hyperaldosteronism, and that is all about the test of Captopril challenge test and all about ruling out primary hyperaldosteronism. Hope you enjoyed the video.